Coding for chronic conditions. Now, as many of you know, we're changing from using ICD-9 codes to ICD-10 codes. And the change is based on date of service, not date of claim submission. So if you see a patient on September 30th, 2015, we're going to use ICD-9 on that claim no matter when we submit the claim, whether we submit the claim on the 30th or whether we submit the claim in October. And if you see a patient, that same patient on October 1st, 2015, for the same condition, you're going to use ICD-10 codes when you submit that claim. So I'm planning on going on vacation September 30th, and I hope some of you will join me. I do think it will be prudent to have cash or a line of credit on hand for that time period, because although you may be ready and your clearinghouse may be ready and most of your payers may be ready, if even one or two of the small payers aren't ready, or if there's some type of technical problem, we could see some delays in payment. And the other reason we might see delays in payment is if you, as coders, are querying our providers. What did you mean by this? I need a more specific code. That'll slow down our claim submission and, of course, payment, which we don't want to have happen. So what does an ICD-10 look like? As many of you know, a complete code could be 3, 4, 5, 6, or 7 characters long. And the characters, the place in the code has meaning. So the first 3 is the category, the 4th is etiology, the 5th anatomic site, the 6th severity, and then there's a 7th character extender in some chapters. It's big. That's one thing we'll say about ICD-10. We're going from about 14,000 ICD-9 codes to about 70,000 ICD-10 codes. And of course, hospitals, not us, hospitals are going to have to use ICD-10 procedure codes when they're submitting claims for surgeries. But we're going to continue to use CPT codes to describe what we do for patients. Now, when we start this, one of the things is every single code is changing, of course, from ICD-9 to ICD-10. It's not a revision or an update. Everything changes. But some things remain the same. And what remains the same are some of the rules that we use. And 2 of those conventions, not elsewhere classified and not otherwise specified, work exactly the same as in ICD-9. So although the codes are changing, remember that some of the rules remain the same. Not elsewhere classified, I wanted to say satisfied, and of course we want to be satisfied with our diagnosis coding. Not elsewhere classified means that there's not a specific code for this condition. The diagnostic statement is specific, but the coding system isn't specific enough. You would think with 70,000 codes, they could have named every single condition ever thought of, wouldn't you? But when we have a code that is NEC, that's good to go, a lot of those end in .8 in both ICD-9 and ICD-10. And if you have a program that lets you look at synonyms, when you click on that, you'll see a list of synonyms that will be your code. So you're good to go. Now, not otherwise specified is the equivalent to unspecified. Now, it is sometimes the most specific code you can find. Even though it is an unspecified code, there isn't a more specific code for the condition that you're looking at. Sometimes I hear coders saying, oh, when we get to ICD-10, everything that's unspecified is going to be denied. I don't think that that's possible because the codes that are unspecified are sometimes the only code that you can select. Now, that's not always the case. So if you're looking at your ICD-9 codes and you're thinking about translation or mapping into ICD-10, if you have a lot of codes that end in .9, take a look at those and see if you couldn't make them more specific. And I'll give one example. I'll give 2 examples here. 465.9, a URI, you probably aren't going to find a more specific code for that if you don't know the exact place in the system that that patient has the upper respiratory infection. So I'm going to call that, even though it's an unspecified code, specific enough to describe a URI. Whereas cellulitis 682.9 is site unspecified, and there are 8 perfectly good cellulitis codes above it for cellulitis of the face, the arm, the trunk. So if you run your ICD-9 report and you see that you have a lot of codes that end in .9, take a look at those and try to, even now, begin to use more specific diagnosis codes. It will help you in October. This is another rule that is the same from ICD-9 to ICD-10. It's we, on the physician side, don't code probable, possible, suspected, could be, might be, shoulda, coulda, woulda in our diagnosis codes. If the patient doesn't have a known condition, we code the symptom, the sign, or the abnormal other reason for the visit. We don't say she, quote, possibly could have a sexually transmitted disease. So that hasn't changed from ICD-9 to ICD-10. Here's some guidance for us, again, from the guidelines, and it says we're going to code an ongoing condition as often as we treat it. So if you see that patient for gout, hypertension, and chronic kidney disease every week for 10 weeks, you're going to code those conditions as often as you've seen them. And it also tells you, look at this second bullet, code all documented conditions that exist at the time of the encounter visit and require or affect patient care or treatment, and then don't code conditions that aren't there anymore. So if you're working in a surgical specialty and you're planning to schedule the patient for surgery, but you say 1, gallbladder disease, 2, peripheral vascular disease, and you want that patient to go back to see either their primary care physician or the vascular surgeon before the gallbladder surgery, then you should code the vascular surgery. 1, gallbladder disease, 2, peripheral vascular disease. Please go see the vascular doctor before we do the surgery. Those codes should be submitted on your claim form. And one of the reasons is because many of our payers now are assessing how sick our whole population of patients are and are assigning risk-adjusted factors to the diagnosis codes that we submit. We've known that Medicare Advantage plans have been doing this for a while because they come to our offices and want to pour through our records to find all of the patient's conditions because they're paid a variable rate based on how sick the patient is. But now we, on the physician side, we may be joining accountable care organizations or other kind of shared savings plans with Medicare or with our commercial contracts, and that's going to vary our payment, not on the individual claim, but at the after the contract year. It may vary our payment with giving us either a bonus or a penalty, depending on how sick the population of our patients is and what our utilization, quality outcomes, and patient satisfaction scores are. So document and report your chronic conditions specifically, particularly those with complications, as we'll talk about. And finally, before we get to talking about some specific chronic diseases, let me talk about history of. This is an error I see in ICD-9, and I hope we'll stop making it in ICD-9 and won't make it at all in ICD-10. If you have a patient who doesn't have the current condition anymore, they don't have colonic polyps. The colonic polyps were removed at the colonoscopy 3 years ago. They have a history of colonic polyps. Then we use the history of code. We don't use colonic polyps. Same thing with breast cancer. If the patient has no evidence of the disease and isn't being treated for the condition anymore, then we don't continue to report the 174 diagnosis code. We report now a V code, will be a Z code, personal history of breast cancer, personal history of, or family history of some kind of condition. Okay, so let's take a look at diabetes coding in ICD-10. So when we're coding for diabetes, the first thing we do is identify the type of diabetes, just like we do in ICD-9, but they've given us a few other choices of types. Is it drug or chemical induced due to an underlying conditions, are more typical and familiar, type 1 or type 2, or other unspecified type, which is listed on the bottom there. So first we identify the type of diabetes. And type 1 is E10 and type 2 is E11. When I've got that period dash at the end of the code, that's telling you this is not a complete code. There are some 3-character codes that are complete, but when you see this dot dash in the index or you see a check mark in the tabular listing, you know you don't have a complete code. So first we've identified the type, and then we identify any other manifestations or complications. And we already do this in ICD-9. We have codes with or without symptoms. But this explodes in ICD-10 and is part of the reason why we have so many more codes. The other reason is trauma. Those are two of the reasons, trauma being the biggest. But we're often asked to identify the condition without complications or with, and then there are a list of specific complications. So major depressive disorder without complications, major depressive disorder with a list of them. So here are the ones for diabetes. We've seen these before in ICD-9. There are a long list of them. And if we were coding for a patient who had diabetes, we would try, and that patient had complications, we should code for those rather than using just the 250.00 or 250.02 codes. In ICD-9, diabetes is described as controlled or uncontrolled. That distinction goes away in ICD-10. So it's diabetes without complications or with a specific list. And then those are combination codes just like in ICD-9. Both ICD-9 and ICD-10 say for some of these complications, use an additional code to identify manifestation. So if we're looking at a patient who's got diabetes with neurological complication, it'll say use an additional code to identify whether it's, mononeuropathy or what kind of neuropathy the patient has. If it's a patient who's got an ophthalmological complication, it'll say use an additional code to identify manifestation such as diabetic glaucoma. So you want to make sure that you're doing that now in ICD-9, getting in the habit of it so those codes are in the patient's problem list now, and that you continue to do that in ICD-10. It's really important if you're going to be part of an ACO or if you have any risk-adjusted contracts. Okay, so here is just a couple of examples of the diabetes codes because there are pages of them, obviously. E10.43, type 1 diabetes with diabetic autonomic polyneuropathy. E11.65, type 2 diabetes with hyperglycemia. E10.319, type 1 diabetes with retinopathy. As you look at these codes, when I first started looking at these codes, the thing that came to my mind was, I don't think I'm going to be able to memorize very many of these. Now, like in ICD-9, ICD-10 has an instruction for us which was assigned an additional code for current long-term use of insulin. And in ICD-10, that is a Z code, Z79.2. So here's just a crosswalk here. Type 2 diabetes without mention of complication, not stated as uncontrolled, is 250.02. And here's an example in ICD-10 of a code that ends in .9 but is a specific code. E11.9, type 2 diabetes without complications. So just because it ends in .9 doesn't mean it's unspecified. Some codes are unspecified. They end in .9, .90, .10, some of them, but some of them are specific codes. And if we had a patient who had type 2 diabetes without any complications, we would be happy for that patient, and we would code E11.9. Now switching gears to another condition, obesity. Obesity doesn't change too much. We have a little bit of different wording in ICD-10, but here are the distinctions. Obesity that is drug-induced due to excess calories, morbid or other, and then morbid/severe with this hypoventilation syndrome, overweight, and then it gives us this note, use an additional code to identify BMI if known. And I'm going to talk about that again in a minute. But here are the codes in ICD-10. Morbid obesity, drug-induced obesity, overweight, other, and unspecified. So of course we would try not to use that obesity unspecified code, E66.9, if we had a code that was more specific on top of it, listed before it in the E66 category of codes. Now BMI are in the last chapter, the BMI codes, the last chapter in ICD-10. And my recommendation is that we would assign a code that describes the patient's BMI for patients who were severely malnourished and patients who had morbid obesity. So anything under 20 and over 40, I would assign a code. If you know that you have a commercial contract that gives a risk-adjusted factor for overweight, you might do it, anyone from 30 on. 25 to 30, I probably wouldn't bother assigning a code, but you might make a lower threshold for yourself. And this is one condition that a coder can assign. So a coder can read the note that the nurse has calculated the BMI, and he or she can assign the BMI code based on that. Whereas a coder couldn't look at the BMI and say, oh, this patient is morbidly obese. We can't diagnose that. We would, even if we could look at the characteristics of it and see that it met the criteria, because that's a diagnosis that only a physician or nurse practitioner, physician's assistant, only someone clinical can assign. But we can assign the Z68 codes or the Z85 codes for our patients. And I think that if you're using any kind of a risk-based contract, you want to make sure that you're doing that. Now the next set of chronic conditions I'm going to talk about are hypertension, hypertensive heart disease, and hypertensive chronic kidney disease. And then we'll talk about chronic kidney disease. These are the equivalent of 401 category codes and then 402, 403, 404 in ICD-9. And I'm afraid in physician practices, sometimes we miss the 402, 403, and 404 diagnosis codes. In the hospital, they don't admit them because, of course, they've been paid forever based on diagnosis coding. That is, based on how severe the patient's condition is, where we've been paid on the physician side based on CPT code. But this is something that I think you should begin to change now in ICD-9 between now and October 1st, and then certainly make the change in ICD-10. So in ICD-9, we have a hypertension chart in the front of the ICD-9 book. That goes away in ICD-10. And we have these three codes that we would typically use, 401.0 for malignant essential hypertension, and then the two codes we see most frequently, 401.1 for benign essential hypertension, and 401.1, and then 401.9 for unspecified essential hypertension. Those bottom two codes are going to equate to I-10, essential hypertension. Notice that I've used a font that makes it quite clear that the first digit in essential hypertension in ICD-10 is the letter I, then the number 10. This isn't going to matter to us when we're selecting codes in our EMR or picking them out of our practice management billing system, but if we're writing them down, we just want to be aware that the first character in an ICD-10 code is always a letter, the second one is always a number, and then it could be a letter or a number. All right, a patient who's got hypertension only, we're going to code I-10. But there are some combination codes if the patient has hypertensive heart disease. And here, the coder may not assume a relationship between the hypertension and the heart disease. The physician must make that distinction. The physician must say that this patient has hypertensive heart disease due to their hypertension. And then if we do have hypertensive heart disease, we have two types of it. Without heart failure, I-11.0, with heart failure, I11.0, or without heart failure, I11.9. So if you have a patient who, when you look at what the physician says, that they have hypertensive heart disease and hypertension, then you should query the physician if they're using either I-10 or the 401 codes about whether there's a relationship between them. And then, of course, we have the distinction of with heart failure or without heart failure. Now, it's going to not surprise you that if the patient has heart failure, that we're going to add an additional code to specify the type of heart failure. If you have a patient where there is not a causal relationship between the hypertension and the hypertensive heart disease, you use I-10, and then you add an additional code for the heart failure. And if there is a causal relationship, you use a code I-11, and then you add an additional code for the type of heart failure. If the patient has hypertensive chronic kidney disease, the coder may assume a relationship between the hypertension and the chronic kidney disease. And in that case, we're going to choose a code from the I-12 category. And notice that at the top, that I-12 dot dash, that means we're going to need an additional character. I-12.0 is hypertensive chronic kidney disease with stage 5 or end-stage renal disease. And if you have a patient with hypertensive chronic kidney disease and their chronic kidney disease is stage 1 through 4, we use I-12.9. And the coder, as I said, may assume this relationship. Now, what about the patient, this poor patient who has all three, hypertensive heart and chronic kidney disease? In that case, we're going to use a code from category I-13, and we're going to have a distinction with heart failure or without heart failure. There are going to be different codes for that. And we're going to use an additional code to identify the heart failure and the chronic kidney disease, just as we would have expected. Now, hypertension coding in ICD-10, when we get there, it says use an additional code to identify, and then it is smoking status. The exposure to environmental tobacco smoke, history of tobacco use, occupational exposure to environmental smoke, tobacco dependence, or tobacco use. So a patient who used to use tobacco, we can put that history of tobacco use. Tobacco dependence, the second from the bottom, F17 dot dash, that is the equivalent to 305.1. That's the mapped code there. And it is a code in the mental health section of the book, whereas tobacco use is factors influencing the status of health of the patient back in that last chapter. We as coders are not going to make the determination, oh, she smokes 7 cigarettes a day, that's dependence, or no, that's only use. Those are clinical definitions, and if we want our clinicians to be making the distinction between dependence and use. We as coders aren't going to do that. And that note, so it looks like I haven't changed the slide, but I did change the slide because this note appears very often in ICD-10, this smoking status. Use additional code to identify. And we're going to find it in the hypertension, of course, cardiovascular, in the neoplasms chapter around cancer diagnoses. Find it all through the heart chapter, through the respiratory chapter. When we're looking at asthma and COPD, use an additional code to identify. So these 5 codes are codes that we will see frequently, and we'll apply them, we'll append them as needed on our patient's charts. Now, how about chronic kidney disease? There is only a slight change in chronic kidney disease from ICD-9 to ICD-10, and it's in the code first note, because we've got really almost a one-to-one match between ICD-9 and ICD-10. But ICD-10, when we go to the chronic kidney disease section, says code first any associated diabetic chronic kidney disease. And you can see if you remember back from the diabetes codes, the E08, E09, or E13, those were those diabetes codes that we didn't see that often. E10 is type 1, and E11 is type 2. So E10.22 is type 1 diabetic chronic kidney disease, and E11.22 is type 2 diabetic chronic kidney disease. It tells us to code first hypertensive chronic kidney disease. Remember, we saw those codes in the I-12 and the I-13 category. And then to use an additional code to identify chronic transplant status, to identify kidney transplant status if applicable, and that's a Z code. I'm sure those of you who've been learning ICD-10 know that what were the V codes become Z codes in ICD-10. But after that code first instruction that we have, the stages of the chronic kidney disease, those codes are just about exactly the same as in ICD-9. They're going to cross, and we're not going to really have any trouble coding for those conditions. All right, how about coronary artery disease and angina? So we do have now, and we did before, a combination code for coronary artery disease with angina. If a patient has an active MI and coronary artery disease, we sequence the MI first. That is, the patient's in the hospital having had an acute myocardial infarction and they have known coronary artery disease, we do the MI first. We would do that the same now in ICD-10. Excuse me, in ICD-9. The late effects of a cerebral vascular accident are in this chapter, but we use those for late effect codes. When you look at those, you'll see is the patient, what are the late effects? Does the patient have hemiplegia, paraplegia, whatever they are? We see those there. An acute MI, the only real change between ICD-9 and ICD-10 is the duration of when we call it acute. Because we call an acute MI now in ICD-10 an MI that's happened in the past 8 weeks. That shortens to 4 weeks in ICD-10. But other than that, the coding's going to look very similar to you. Is it a STEMI or a non-STEMI infarct, and what's the location of the infarct, which our physicians know because all these patients have the diagnostics to tell them that right away. Angina, in ICD-10, we have unstable angina, angina with documented spasms, and then other forms and unspecified. So that looks pretty much the same as ICD-9, little change. Coronary atherosclerosis. First, we're going to identify the site. So we shouldn't be using always the equivalent of 414.00 unspecified, whether it's native, graft, or transplant. And often that information is in the patient's record, but may not be in the problem list. So that's a place where we would be now, if we have the time, updating the problem list to the more specific code in ICD-9 so that when we see that patient in October, we can have a specific problem in ICD-10. And then we identify whether the patient does or doesn't have angina and assign an additional code for chronic total occlusion due to calcified coronary lesion and for smoking status. So coronary atherosclerosis doesn't change too much between ICD-9 and ICD-10. In terms of the extremities, we have more choices. If you've been listening in on these, you know one of the things about ICD-10 is what the realtors tell us, location, location, location. It gets much more specific. That's part of how we got so many codes from ICD-9 to ICD-10. So the location is specific, there are more complications, and we have laterality. So if we're looking at atherosclerosis of the extremities, we would have one without complications. That's always an option. We always hope that. And then it is with specified complications: gangrene, claudication, ulceration, ulceration and claudication, then upper or lower or bilateral, and right or left. If we have an option for bilateral and the patient has it bilaterally, we choose that code. There are some codes that don't have a bilateral code, like knee pain. The patient has right knee pain and left knee pain, and there's no bilateral code. We code them both. And then these codes, if the specific complication is ulceration, it tells us, not surprisingly, use an additional code for the ulceration. So here's some examples. 170.244, atherosclerosis of the native arteries of the left leg with ulceration of the heel and midfoot. The locations become very specific. And the one at the bottom, of the native arteries of the extremities with intermittent claudication, bilateral legs. We have these same kind of increases in specificity and distinctions for varicose veins in the I-83 category, varicose veins asymptomatic, and of course we're going to have left, right, bilateral, and unspecified. We know where the varicose veins are though, so we're not going to choose unspecified. And are they complicated by inflammation, pain, ulcer and pain, or other complications? And of course, if with ulcer, we're going to identify the site of the ulcer and use an additional code. And we're going to talk about ulcers, pressure and non-pressure ulcers later on in this session. So I'm going to come back to that. But here are some examples. I-83.813, varicose veins of bilateral lower extremities with pain. I-83.023, varicose veins of left lower extremity with ulcer of the ankle. And then, because we have an ulcer, we go and code the ulcer. L97.322, non-pressure chronic ulcer of the left ankle with fat layer exposed. So the ulcer codes increase because we have increased specificity for location, and the staging is built into the ulcer code. So we have a description in there about how severe the ulcer is, and we report that right on the claim form. And in ICD-9, we used two codes to do that. We'd have one for the location and the other for the severity. Now those are combination codes. For valve disorders, we go from 3 codes to about 15 codes. So the mitral valve disorders are now described as non-rheumatic mitral valve disorders, and then we've got 5 options there: aortic valve disorders and tricuspid valve disorders. And of course, those are going to be with and without complications. Lipid disorders in ICD-10 look very much like lipid disorders in ICD-9. So we've got the list of them there, the types of lipid disorders, and when we get to lipidemia, expanded on the next slide, here we are. Mixed, pure, other. I don't think we'll have any problems with coding these in ICD-10. They look very similar. They haven't expanded. They're right there for us, just as we expected them to be. Now, how about personal history of? I mentioned earlier in the session that if a patient no longer has evidence of the disease and isn't receiving any treatment, that we don't assign a cancer diagnosis to them anymore. If they had colon cancer, it was resected, radiated, and destroyed 10 years ago, we don't continue to assign colon cancer to them as a diagnosis. We say personal history of. And these personal history of malignant neoplasm chapter codes are in the last chapter, in the V codes in ICD-9. There's Z codes in ICD-10. There is a slight increase in location for these, but otherwise they work pretty much exactly the same. And we'll go back to that chapter and find the personal history codes and use them. All right, I talked before about these pressure and non-pressure ulcers, and both the pressure ulcers and the non-pressure ulcers have this same great increase between ICD-9 and ICD-10. And they also become combination codes for location and severity. So in ICD-9, we have a pressure ulcer of the buttock, and we would also have another code for the stage, whereas in ICD-10, we have an unspecified buttock, right or left, and then there would be an additional character for the stage of the ulcer. This is an example. Whenever we want to show how a few codes can go to a lot of codes, that's it in ICD-10. There's much greater specificity for location and for the stage. And I'm going to go back here. We see these L8-9 are the non-pressure ulcers, and we saw the, are the pressure ulcers, and we saw the example before with the varicose veins with a non-pressure ulcer. Those are in the I'm going to go back so I don't misspeak. L97 categories of codes in our skin chapter. So the greater specificity and the stage built into the code. When we see a pressure ulcer, when we go to the book, it tells us code first any associated gangrene, and that's in I96. So if you had a patient with a pressure ulcer, we would go back and code that first. And here are just some examples. L89.121, pressure ulcer of the left upper back, stage 1. L89.323, pressure ulcer of the left buttock, stage 3. When it says left upper back, you know you're going to have a code for left lower back, not to mention the right side as well. And these would be codes that you would assign as many as codes for as many ulcers as the patient has, just like in ICD-9. All right, bronchitis. So bronchitis, in ICD-10, first we're going to identify the type, and those are listed, and then for COPD, with acute lower respiratory infection, with an acute exacerbation or unspecified. Bronchitis is something I think we could get more specific on in ICD-9 and do a better job when we go to ICD-10. If you opened up your ICD-9 book and looked at 496 COPD, the code that we all use morning, noon, and night, it says it is an unspecified code for chronic obstructive pulmonary disease, and if the type of pulmonary disease is known, to use it. So that's one thing that I would do today. I would run a list of my patients for whom I'm using 496, and I would try to update those problem lists for chronic patients that I was seeing frequently to the more specific ICD-9 code, because then it'll cross better to an ICD-10 code. 496 is going to cross to a very unspecified ICD-10 code. And why do we care? Again, I don't believe that the payers are going to start denying everything. Particularly for an office visit, almost any code shows the medical necessity for an office visit. But I think that that moving to ICD-10 is the first step towards tightening up on these unspecified codes. And if we have a more specific code, it is going to risk adjust. So if we enter into it, some of them are, not all specific codes risk adjust, but certainly if we're in the respiratory conditions chapter, some of those more serious and specific codes will risk adjust. And if you're ordering a test, either a diagnostic test or trying to pre-authorize a procedure, a specific code is required. So although I'm not the sky is falling kind of coder about unspecified codes, I want to encourage us to be always moving towards more specific codes. So here's some examples. Simple chronic bronchitis. Take a look at J44.0, chronic obstructive pulmonary disease with an acute lower respiratory infection, or J44.1, chronic obstructive pulmonary disease with an acute exacerbation. So rather than using the equivalent of 496, we would use a code that specifically described the patient's conditions. And all of these codes in the respiratory chapter, bronchitis, asthma, emphysema, they all have that notation. Use an additional code to identify the smoking status, if applicable, and they would list those 5 codes that we saw early on in the presentation. Here is emphysema. You can see we have specific types. Now you say, what if you're in the office and you don't have the diagnostics to know what type it is? Then you're going to have to use unspecified emphysema. You can't say, well, I'm going to guess it's unilateral or panlobular. You're going to use the unspecified code if you don't have a more specific code. However, If you then have a patient who has the diagnostic test that tells you, or they've been in the hospital and while they were there it was identified as a specific type, change that on their problem list right away so that you don't have to go back through and look for that again a year later. Asthma, they tell me, is now being defined more like clinicians want to define it. And when I talk to clinicians and go through some examples, sometimes they say to me, oh, we don't use that definition anymore. How come ICD-10 is using it? But asthma is one where they tell me this is how we want to define asthma. For asthma, we have codes for mild, intermittent, mild persistent, moderate persistent, severe persistent, and then there are two codes for other specified type, exercise-induced and coughed, which we also have. There's a code for an unspecified type of asthma. We're going to try not to use that. And then identify also, is the moderate persistent asthma uncomplicated, with an acute exacerbation, or with asthma spasmatic? Too many ASTs there, asthmaticus. So here are a couple of examples, and it would tell us to use an additional code to identify the status. So this is all J45.21, mild intermittent asthma with an acute exacerbation, J45.42, moderate persistent asthma with status asthmaticus, and J45.20, mild intermittent asthma uncomplicated. So the descriptions of these become more specific, and here's an example where the problem, if we had a problem list and we had ICD-10 codes assigned to it, this code may change, because when the patient comes in with their acute exacerbation, we're not going to choose J45.20 uncomplicated. We're going to choose J45.21 mild intermittent asthma with acute exacerbation. Although I've said we should be updating our problem lists so that they're specific when we move to ICD-10, that doesn't mean that we never change the codes we select in the problem list. All right, signs and symptoms. These work exactly the same in ICD-9 as in ICD-10. It's when we don't have a definitive diagnosis. And these are in Chapter 18, and I've just listed some. Edema is a little bit different here. We have localized, generalized, or unspecified. Again, we're going to try not to use that because we'll know if it's localized or generalized. Some codes, some conditions get more than one code. We have more specificity about location and without complications or with, and GERD's one example. K21.0, GERD with esophagitis, K21.9, GERD without esophagitis. And if you don't know whether the patient has esophagitis, we're going to use without. We're not going to assign a complication if we don't know that the patient has one. There's some status codes. Some of us are using these now, and it depends on your practice whether you are or not. Long-term use of insulin or anticoagulants, we should be reporting that. Colostomy or other kind of artificial opening, so a patient who has a breathing tube, who's got a PEG tube, whatever, we're going to report those statuses. Presence of a pacemaker, and then maybe personal history of nicotine dependence we could be reporting. Pain coding in ICD-10 happens in a lot of different chapters, just like it does in ICD-9. It can be found in the signs and symptoms chapter, musculoskeletal chapter, where there are a lot of pain codes there. And then acute and chronic pain not elsewhere classified is in the neurological chapter, just as it is in ICD-9. So a patient who's got chronic pain, a pain syndrome. And then, maybe the patient has ear pain or eye pain. We find that in the chapter related to those organ systems. Here we have the codes for chest pain. In ICD-10, it gets slightly more specific, but I don't think it's going to cause us too much problems. They've changed definitions. So if we have looked at, on the ICD-9 side, 786.52, painful respiration, I think that's going to cross exactly to R07.1, chest pain on breathing. About 25% of codes cross, but most of those, 24% of them, with a change in description. But it is the right code. And if you're using a translation program, it'll say it crosses directly sometimes. It doesn't give you options. It crosses to that code. Here's an example. Headache in the signs and symptoms chapter would be equivalent to our, I think it's 784 code for headache. 784, I can't remember that one. But in ICD-10, R51, a complete code, 3 characters. Whereas if we know the type of headache, then we go to the nervous system chapter. Is it a migraine, cluster, stress headache, whatever type of headache it is, and we find the more specific code. Pain in limb. Right now, if we had a patient with knee pain, we'd use pain in limb, lower leg. Be the same as calf pain, pain in limb, lower leg. But in ICD-10, the locations get much more specific, and we now have pain in joint, pain in knee, right, left, or unspecified. There's no code for bilateral knee pain, so if the patient had both right and left, we would code both the right and the left pain. All right, so I am coming to the end, and we're going to answer some questions, but my advice now about what to do as we're getting ready, we have only a few short months left if you're listening to this before October 1st. If you're listening to it after October 1st, it's too late to have cash on hand, but maybe you could have get a line of credit. Take a look at your mappings. So I hear this all the time. Our physicians think we're done. We don't have to worry about ICD-10 because our computer system is already showing the ICD-10 codes. We're already able to see those. Aren't we done here? That's what the doctors say. So we coders have to take a look and see, are we done here or not? And how are we going to do that? We're going to look and see if those mappings, number one, are correct. And we're going to do that by getting out our ICD-9 book and our ICD-10 book and looking at them. Or are they all unspecified? Because let's go back to the knee pain. I'm going to go back a slide here. If you have 719.46, your system, if it's going to map, it's going to map to M25.569, unspecified knee pain, because it can't choose whether it was the right or the left, can it? It's impossible for the system to know that. It's not reading in the physical exam or in the HPI whether it was the right or the left pain in the lower limb. And it might not even choose knee because this 719.46 is lower leg. It might go farther down to unspecified portion of the lower leg, unspecified whether it's right or left. So the mappings aren't going to work if two things. If our code is unspecified in ICD-9 but could have been specific, but it isn't, or if it's a specific code in ICD-9 but there are just more options in ICD-10, so the system can't pick the more specific code. So take a look at your mappings. Drive out your unspecified codes whenever possible. Do buy an ICD-10 book. There are some clinicians who are very familiar with and facile with their ICD-9 books. But mostly, clinicians are looking up these codes in their systems. They're not running down the hall to find the ICD-9 book. Whereas we coders, even though we have electronic search, and I use an online program and I can see everything, I still sometimes like to get my book out and look at the codes there. Buy an ICD-10 book for your practice, even though it says draft version. The code sets are frozen because we're only adding new codes if there's a new kind of virus that we find. So buy a book. And coders, you want to look at the general guidelines in the front of the book, whereas again, we're not going to make our poor clinicians read the general guidelines in the front of the book. We're not that mean, are we? We're going to print out our common diagnosis codes, print out the list of the most common diagnosis codes, and then look at the clinical documentation and identify what else needed to be there in order for us to be able to code most specifically. Okay, so Holly, I think I'm ready for questions.
Great, Betsy. We have a few questions this morning. Let's start with this one. Why are we still using the term essential hypertension? This is something that went out of use in 1950. Is this term coming back as part of ICD-10?
Oh, I'm so sorry to hear that, and I like to answer these questions starting out saying, oh, that's above my pay grade. But the way I'm really going to answer it is that ICD-10 was developed by the World Health Organization, and then when it came to the U.S., the CDC and the American Hospital Organization adapted it into the clinical modifications version that we're using. So sometimes clinicians say to me, like the definition of asthma, this is how we have been, this follows the clinical definition. And sometimes I hear this in psychiatry, and now I'm hearing it here, where they say these codes don't follow exactly the way we're thinking about the disease or the way we would be diagnosed with the disease. So all I can say about that is how they've defined them, and we're going to have to use them as best we can and hope that we can, even if the term isn't exactly what we would have chosen, that we can select the code that most accurately represents the condition that our patient has. Holly? Whoops, have I lost you, Holly?
So sorry, I think I was muted. Here's our next question. How do you code a main diagnosis with multiple complications, such as diabetes plus kidney and eye complications?
Oh, that's a good question. So we wouldn't code the main, if we're going to say, would we code, I'm going to use the equivalent of ICD-9, and then I'll translate that into ICD-10. We wouldn't code 250.00 and 250.70. So I wouldn't code that the patient has diabetes type whatever, and then code, because that's a without complications code, and then code the diabetes with complications. We would go to the severity first. And in ICD-9, the equivalent would be we wouldn't code type 2 diabetes without complications E11.9 and code type 2 diabetes with peripheral neuropathy or with neurological manifestations. We would select the code that was with the complication. Now, supposedly, theoretically, as we like to say, we're allowed to use 12 diagnosis codes on a claim form with the 5010 format change that we had, however many years back that was. But in practice, what I hear when I talk to practices is that either their system, their own practice management system, or their own EMR, or the clearinghouse, or someplace in between, doesn't allow them to use 12 diagnosis codes. They may be only able to select 6 or 8 on their encounter form, their electronic encounter form. So I would say, you know, code as many conditions as you can, but after a point, you know that ask your coders how many of those conditions are actually going. And then if I had 2 diabetes codes with complications and 2 heart codes with complications and 2 respiratory, I would code 1 from each major condition before I started adding additional diabetes diagnosis codes. So the first thing I'm going to say is check and see how many are actually being transmitted, even though we know we're allowed to do 12, and then rank them in order of the conditions that you addressed. So you don't want to put a condition that was peripheral or that you reviewed but that someone else managed in the first position. Put the conditions that you're managing, put them in that order, and the order of their severity. Holly?
Great, thank you, Betsy. Some of our patients are complaining about the diagnosis coding we use for the blood work in their annual exams. They call us up and ask us to change the code to screening so it will be covered. Are we allowed to do that?
Oh, that's such a hard question. And we love getting those calls, don't we, where the patient calls us up and says, my insurance company told me you coded this wrong, and if you just code it right, it would all be paid. Of course, we don't know what the insurance company told them, but it's like a game of telephone that we aren't enjoying that much. So here's what has happened now. Many patients have first dollar coverage for preventive or screening services. You know, in times past, they'd call us up and say, my insurance won't pay for, because you coded it as screening, would you please put down hypertension so I can get it paid? But now that's changed. We have first dollar coverage for many preventive and screening services. Many of our patients do. but their other services go to deductible perhaps. So if we put down a diagnosis, the patient may end up having to pay because it went to their deductible. But if the patient has the condition, if they already are diagnosed with hyperlipidemia, we can't code screening on the lipid panel because we aren't screening, we're monitoring that patient's condition. So we want to make sure that even though the patient wants us to quote-unquote change the diagnosis code, if they already have the condition, it's not screening, and we're very sorry because we know they're going to end up paying for that, but we can't just change that code. Holly?
Okay, this is our last question.
Okay.
We have one more question. We see our colon cancer patients back after their treatment has stopped. What diagnosis code would we use for that?
So for that, you have to use personal history of colon cancer, and that's a V code now, and it'll be a Z code in ICD10. We don't want to, because if you assign colon cancer, you're basically telling the payer, this patient has cancer. And if the patient doesn't have cancer anymore, we don't, if I were the patient and I had a personal history of, I had beaten cancer, we always use those words for cancer, if I had survived the treatment and the disease, and it was 6 years later and I went in for my surveillance visits, I don't want you to tell my insurance company I still have that. I want you to tell my insurance company I have a personal history of. So that's the correct code to use. Now, we've put up the slide for with Holly's contact information, and we're going to see you next week for Injuries Are Going to Hurt, Coding for Trauma.
Thank you so much, Betsy. Thank you to everyone for joining us on the call today. If you do have questions, as Betsy said, feel free to email them to me, and we'll see you next week. Okay.